Welcome to Healthcare by the Numbers, a podcast that uncovers what's driving healthcare transformation. Join us each episode as Caravan Health, now part of Signify Health, industry experts interview the brightest minds inspiring healthcare innovation and discuss the numbers which have shaped their thinking.
Hi everybody, my name is Josh Schlaich. Welcome to the Healthcare by the Numbers podcast with Caravan Health. We are at the 6th Annual Caravan Health Accountable Care Symposium in San Diego, sunny San Diego, a little cloudy right now, but we're here talking a little bit more about value-based care, value-based payment, and in particular the interplay between specialty and primary care in value-based payment. I am joined by Francois de Brantes, who is a Senior Vice President at Signify Health, and can you just give a little bit of background on yourself?
Sure. I have been working on trying to advance payment reform and value-based care in one way or another for a couple of decades, and have been with Signify now for a little over 4 years, and really excited about the transformation of the company and in particular with the inclusion now of Caravan.
Excellent. Well, excited to talk to you a little bit more about this topic, which I know is an important one. Relative to, we've seen a lot of value-based payment, value-based programs, value-based initiatives focused around the primary care space. And I know that you have been intimately involved in how does value-based payment really start to play into the specialty care environment. We have BPCI Advanced and other specialty-focused type initiatives, but how have you seen those evolve over the last 10 to 15 years?
It's a great question, and I'm going to try to answer it by focusing on a few things. One, the different needs of different types of payers, from employers to Medicaid to Medicare. And in the Medicare world, there has been and continues to be a very strong push to have all beneficiaries in a relationship with, let's call it a principal accountable provider or a principal managing provider. And for years there's been, I think, a large consensus that primary care should be at the hub of that relationship. It's not necessarily the end of the path for the care management of the patients, but it is a hub, and we need to think about that as a hub. So in some instances, that hub is where the majority of the activity for the beneficiary may occur, but in many other instances, it truly is just a hub, and then there are many spokes, and the spokes go and extend out to specialty care, which is really important for a lot of beneficiaries who have more complex conditions. And so the Medicare world is one in which you do have a lot of obviously older Americans. They have combinations of conditions. They need coordination, but they also need high degrees of specialty care. If we switch a little bit to Medicaid, think of Medicaid world where very heterogeneous population, a lot of them women having babies, and so in that instance they get enrolled in Medicaid because they're pregnant. And do you really need a PCP at the hub? Probably not. So it's more specialty care oriented with an obstetrician really as the central node for that woman's health. And then you also have patients with very complex conditions or combinations, mental health, behavioral health, and it's unclear whether the primary care physician has a central role or maybe just a smaller coordinating role. And then you get into the under 65 population where, for all intents and purposes, a very significant number of covered plan members only have a relationship with a primary care physician and only get their care from a primary care physician. And in fact, a lot of employers have gone to do direct contracting with primary care physicians who end up by having that almost exclusive relationship with plan members. So we really need to think about this combination of primary and specialty care in light of the different types of patients or plan members or beneficiaries that a primary care practice may see. And we have, as a result, seen a little bit of specialization, a subspecialization even in those practices, with some seeing only Medicare beneficiaries, some seeing only employed populations. So value-based payment, I think, has been at the root of this degree of transformation by changing the relationship fundamentally from one that's really focused only on giving a set of services to individuals to one that's much more comprehensive and holistic. And I think that's what's created these new hub and spoke models.
You know, as you think about the hub and spoke model between the primary and specialty care providers, you know, obviously primary care providers in accountable care relationships, like in accountable care organizations, I would think they're fairly used to this type of concept, whether it's a capitated payment or total cost of care payment. But specialty care providers, just anecdotally speaking, I think there's been a little bit more of a cultural challenge in sort of accepting those risk-based payment models. What are some of the most common challenges you have seen, if you have seen those, and what are the types of payment models and initiatives that you've seen work?
Yeah. Again, great question. And I'm going to bring in a few numbers because I know the focus of these podcasts is really on numbers. And so think of today about 30%, I would say, of primary care practices have a strong value-based payment arrangement, and it can be either a fixed per member per month payment or a combination of a smaller care coordination management fee per patient plus a total cost of care contract. And at the root of that payment transformation, you also have had the response of industry by creating lots of primary care focused companies that have brought capital, that have brought expertise, systems, and that wouldn't have happened without the payment change. Right. But it also goes to a portion of your question about the hesitancy typically of physicians to take downside risk or take risk generally. So if you've got an organization that has capital that backs you up, then you can stay independent and you can still get into these payment arrangements and start taking really a much more active role in that hub and spoke model and full accountability for the patient. And we see a variety of different payment models emerge from that. And then where it becomes really interesting is when you do engage specialty care physicians along with the primary care physicians and not just have a referral spoke, but also have a payment spoke.
Right. No, that makes a ton of sense. Tell me a little bit about sort of that dynamic and that interplay and how that's really played out in a program like BPCI Advance. And for those that are unaware or not as familiar with the program, Bundle Payment for Care Improvement Advance, a Medicare program where there was a series of specialty line or service line oriented bundled payments that were provided by CMS for Medicare patients. So tell me a little bit about how that's played out in that program in particular.
Yeah, and that program in particular has its own unique features, and those unique features were important for Medicare. So back to my earlier comment that when we think of payment models, payment changes, roles of primary and specialty care physicians, it's very important to do that in the context of the population that you're serving. Right. So in the case of the Medicare fee-for-service or traditional Medicare program, you have a lot of beneficiaries who end up by going to the hospital very frequently. Yep. And in fact, there's hundreds of thousands of hospitalizations every year of Medicare beneficiaries. And the goal of the Medicare Bundle Payment Program was really to create better accountability for the care of the patient when they get discharged. And that's because in Medicare in particular, there was a very astute observation that the number of readmissions, so the number of times a beneficiary gets discharged and gets readmitted for complication because they have an acute exacerbation, something happens, was very high, number one. Number two, the choices made by the facilities or the physicians who manage those patients during their stay to post-acute care facilities was somewhat haphazard because you get discharged, and if I'm the hospitalist or if I'm the hospital, my responsibility essentially ends at the door of the facility, and then I'm going to give you some choices of where you can go post-acute, but I'm not intimately involved in that decision-making process, nor am I accountable for that decision. So the bundle payment program was designed to create that accountability beyond the walls of the hospital and really engage the hospitalists, physicians in making choices that were the best for the Medicare beneficiary and led to both better post-acute care, which also meant quicker return to home for the beneficiary, and reduced readmissions. And so it's back to, you create payment models with a specific purpose and with a specific population in mind. And this one had some really good goals that have proven to be very effective because for those participating in that program, they have completely reshaped the way in which they work with post-acute care facilities, the choices that are made, and beneficiary outcomes are typically better. The challenge with that model is that it really didn't relink the beneficiary formally to the primary care physicians or the specialty care providers that are managing them. And that's why the Innovation Center, which runs all these programs, is really looking now at not necessarily how to re-up this particular model, but close some other gaps that become pretty clear, and that is, how do you not take this event as a separate bubble, but instead really rethink the way in which that event is then linked back to the ongoing care and management of the patient, and how do you more formally include the primary care physicians and the specialty care physicians?
Well, it's interesting. We're talking a little bit about the Medicare program, and obviously this being a Caravan Health podcast, Caravan Health is now part of Signify Health. And Signify Health has really been focused in on how do we take some of the best practices, the learning that we've had in the Medicare program, and obviously Caravan focused in on MSSP, us focused in on at Signify Health on BPCI Advanced, and how do we adapt that to other populations? So how have you seen the adoption of these types of payment models, whether it be episodic, like a bundled payment, or whether it be a total cost of care, or in a commercial ACO, on the commercial health plan space? And you had mentioned direct contracts with employers. Have we seen adoption accelerate, or is there still a lot of inertia that's being faced out there in the market?
I don't think it's inertia. I really think it's a lack of understanding of the options that are available, and then oftentimes potential challenges and barriers that employers may face with the plan administrators that they've chosen. But increasingly, there are choices of plan administrators that are very well versed in these types of payment arrangements and who are really trying to get some of this stuff done. And Signify, of course, works with many of those payers. I'd say that the answer to a lot of our joint work with Caravan, now part of Signify Health, is that the model of total cost of care that Caravan has successfully deployed with many providers across the country, and the model that Signify has deployed with many providers across the country, really is a combination, and that where you get the best is by combining the two models. So back to what I was saying about BPCI, you have a bundle which today is treated almost like an insular type of event and not relinked back to the rest of the patient's care. But if you take a total cost of care model and you overlay that on top of a bundle payment model, then you actually are able to focus attention on the specific management of the event and engaging providers and specialty, both primary and specialty, on the management of that event, while at the same time keeping an eye very closely on the total cost of care. So I often tell audiences and whether policymakers, providers, payers, or others, that we have a tendency to think about problems in a very binary way. So let's do total cost of care or bundle payments. Let's focus on primary care physicians or specialty care physicians. Let's do ACOs with hospitals or with someone else, but you can't have both. And the answer is yes, you can and you should always have both. It is an and, not an or, and they work much better together. Primary care physicians and specialty care physicians, hospitals and health systems and primary and specialty care physicians, bundle payments and total cost of care.
It's interesting you say that, because as Signify Health and Caravan Health are coming together, it just so happened that CMS, as they're thinking about the next generation, they're always innovating at CMMI and thinking about what the next model is. They've come out with this ACO Reach model, which really does combine some of the aspects of capitation. There's an opportunity maybe for some episodic type of work in there, and then of course it's a total cost of care arrangement as well. So can you talk a little bit about what your thoughts are on the ACO Reach model, and just some very high level as to how some of the payment mechanisms you see them playing out in the market?
Yeah, well, two important points. So one, ACO Reach to me is the perfect opportunity for the hub and spoke for the and, because you can't really effectuate total cost of care without the full engagement of the specialty care providers, especially in a Medicare fee-for-service population. So you have to have those subcontracts between primary and specialty care providers, really holding the specialty care providers accountable, and they want to be, on the management of the patients that they take responsibility for. Example is when a patient has advanced heart failure, it is not the primary care physician who manages that patient. It just isn't. You have to have a cardiologist. And so you want that cardiologist to really feel the accountability and want the accountability for managing the patient so that they reduce the potential for the patient to have an acute exacerbation, for the disease to progress even more, to try to stabilize the patient as much as possible. That's the specialty care provider's accountability. And the advantage of a program like ACO Reach is that it converts the payment in such a way that the physicians who participate actively in the program really become freed from what I think of as the tyranny of fee-for-service. Because you don't need to have necessarily a specific service in order to get a specific payment. You can change fundamentally the way the contracts work with the primary care physicians, between the primary care physicians and the specialty care physicians and even facilities, in such a way that, back to the example of heart failure, if the cardiologist wants to install a remote patient monitoring device in the beneficiary's home, send someone to help with social care coordination or anything else, even if it's Signify or Caravan social care coordinators and care managers, it's perfectly fine. And you don't have to worry about billing for that particular service or worrying whether Medicare is going to reimburse for that service because you've got a guaranteed payment. So it's for all of us who have been trying to encourage the transformation of the delivery system, it really has been the goal to find ways to reduce the dependency on every individual billed service as the only mechanism to generate revenue for the practice or the provider. And the ACO Reach changes fundamentally that equation. It's also being done to some extent in Medicare Advantage, and we also see elements of this in the private sector. And so we're really hopeful that what comes out of the next couple of years of working on that program will start showing the industry that payment reform does absolutely change the way in which the delivery system functions. And as a result of that change in function, well, you see positive changes in outcomes, positive changes in care.
Excellent. Francois, thank you so much for joining us. It's exciting to hear about sort of what's on the horizon, and as Signify Health and Caravan Health are coming together, how we might be able to help health systems, hospitals, provider organizations, health plans, and employers really navigate this transformational change. Again, this is the Healthcare by the Numbers podcast, live from San Diego. We are at the Accountable Care Symposium, 6th annual. Thanks for listening in, and we'll see you next time.
Thank you for joining us today. You can find more information and episodes on the show's program page on Healthcare Now Radio. Follow the show's hashtag HCBTNpod. We are Caravan Health, and this has been Healthcare by the Numbers. Until next time, take care.